Welcome to this morning's presentation regarding the Affordable Care Act. On behalf of Servant Solutions and Indiana Ministries of the Church of God, we want to welcome you, to thank you for your time and your interest in the topic. Thanks to Eastside Church of God, who have been so gracious in hosting our workshop today. Thank you so much to Jeff and Jim and Servant Solutions for their efforts, and to our presenters who you will get a chance to hear from in just a moment. I wanted to identify several of the goals that we have for our time together. The first one is to demythologize much of the information that's out there regarding the Affordable Care Act. There are lots of urban legends attached to the legislation, and we're not here for the purpose of analyzing it from a political standpoint, but for trying to disseminate some kind of information that will be helpful to churches and nonprofits to be effective in just identifying what their positions ought to be with regard to that. The second goal that we have is to provide churches and nonprofits with the information they need in order to be compliant with the new law, which, as you know, is very fluid. We also want to help churches and nonprofits and their leaders, many of you are among those, know how to find additional information. Where can I go to find out what else I need to know? And then fourthly, we want to try to answer just some of the basic questions that it seems everyone is asking. And so those are the directions that we'll head in a general way. And as Jim already explained, the format will, I think, help us get that material on the table. We hope you leave here knowing just a little bit more than you did when you came. And if you do, then we've at least accomplished a piece of our goals. Again, Servant Solutions and Indiana Ministries welcome you. We are thrilled to be able to make this joint effort and hope that it is fruitful and effective for you. And if you have anything else that you need, just make sure you track one of us down, and we'll make sure you have what you need. Thanks.
We're so honored to be here, and we thank you for coming, and so glad to have Dave and Liz with us. We've asked that you maybe share just a little bit of an overview for a couple of minutes, just your perspective, where you come from the provider standpoint, from the insurance standpoint, for folks to think about, and then we'll begin some question and answers. How about that?
Sure. Thanks, Scott. I appreciate it. I'm Liz Simpkin, and I'm president of the Accountable Care Consortium. We are an integrated delivery system of about 28 hospitals and approximately 4,000 physicians in and around central Indiana. We're a collaboration between Community Hospital System, the St. Vincent Hospitals, and the Suburban Hospital Organization. We're really dedicated to managing care, coordinating the health of whole populations, and so healthcare reform obviously is just an outgrowth of something that we've already been trying to do. As perspective from a provider organization who is trying to figure out how do we financially accomplish those goals, I think we always remember, and we always try to start with, both our business and our mission is delivering healthcare and delivering it to everyone. So we know that removing barriers to care, which is the goal of healthcare reform, is really vital for our whole society. But we also know that costs have been unsustainable at unsustainable rates for years before now. And so healthcare reform only adds greater pressure for how are we as a society going to pay for providing the care that we need to all of our society. So to that end, I think forward-looking providers like ours are really taking the lead and taking the, if you will, accountability to do exactly that. And we believe that we can through a number of things. We know that we can't just do what we've always done. We can't deliver care in exactly the same way and expect that there's any way to pay for it. we can't deliver it in the same way that we always did just by taking a lower price for it either. So instead, what we have to do is take that accountability to say, how do we deliver more efficiently, better coordinated, avoiding the most unnecessary and costly care by doing it right, doing it better, doing better outreach and preventive care. And we believe we can do that, but we also think that providers are in the ideal position to lead doing that. So we'll talk more about all of those things, I think, this morning, but I wanted to share that as our perspective from, again, a group of providers who believe this is our mission and are trying to figure out how we do that for ourselves and for employers and population. So thanks.
Thanks, Liz. Appreciate it. Dave?
Yes, I'm Dave Burnett, and I operate from the broker community. I'm an independent broker, primarily focusing on small group business, which had been asked, what is a small group? Defined by ACA, it's 149 medical lives, okay, or employees. I'm going to try to talk about the things that people are asking me daily, in particular over the last 30 days with the early renewal situation. I am meeting with employers, and I'd like to share with you the things I think the majority are asking me. The first is, what is the employer mandate? Okay, and the employer mandate does not apply to the majority of people I'm speaking to. The employer mandate only applies to large group, which in 2014 is 50 or more employees, or if you've got to go into the full-time equivalence calculation, it applies to them. So the employer mandate does not apply to the majority of small business. What is the biggest concern small business sees with their group health care costs? Because it's been referenced, that's been the biggest issue, and that is community rating. And I don't know if people are aware of what community rating means, but it's going to eliminate the risk factors in ratings, which are going to merge and go into more of a pool. The result of this, we're looking at projections right now, maybe a decrease to certain small groups of 20% in cost, whereas others who've been historically low risk factors are going to see significant increases, potentially 40 to 50%. And as with everything, you know, we're dealing, as it's been said by others, this is a series of moving parts. And there are really no definitive answers at this time, I don't think. Those are the biggest issues we see affecting the small group is the community rating. And we're going to start seeing early January of what impact that's going to have specifically. The other thing, I know we're dealing with many small employers, and as I said, the employer mandate does not apply to the small employer. They do not have to offer group health insurance. If they do not, there are no penalties. So we may see a shift of many going to individual type products, potentially with a stipend from the employer to allow the individual to buy their own coverage. The individual mandate does assess a penalty beginning in 2014 for the majority of people if they don't acquire QHP or qualified health product, okay? The other question we get a lot of, well, do we have employees eligible for subsidies? Would we be better off to discontinue our small group program and allow them to access the subsidies? We don't know. You know, we've gotten past the issue with health care reform that eliminated that consideration in the past, and that was on the individual market. People could be declined coverage, but now they're guaranteed issue with no pre-X. So it opens up that discussion, but there's not an easy answer to that. It's going to impact negatively on some and positively on others. And with one company, it's going to impact differently on both. So we've got a lot to learn. We're going to see a lot more coming out. We'll probably see the true community rates in the latter part of this month. Okay.
Thanks, Dave. Well, just in the course of a few minutes' time, a lot of questions come to mind. We talk about sort of the purpose of our time here together being kind of a focus on small organizations, nonprofits, churches, others that and there are going to be some who provide insurance coverage or health care coverage for their employees, and some that don't. And so today we're going to focus a little bit more on those who do, and kind of how that may play out for them. But we also want to spend some time on the individual because there may be employers that don't provide health insurance coverage, but have staff, employees, parishioners, whoever it may be, that who are asking them, give us some direction. So you made reference to the small and the large employer, Dave. The small employer, the small nonprofit, to distinguish, again, what would be the numbers there as far as the number?
Actually, formerly it was 2 to 49, now it's 1 to 49.
So 1 to 49
Employees.
staff represents a small business
Group.
or small organization, small
Although
group.
that'll change in 2015 and be increased to 1 to 99.
1 to 99 in 2015. So there is that change that kind of evolves
Right.
over the course of time as well.
Right.
One of the things that you kind of raised, you raised that some may ask is the full-time and the part-time equivalent. When you talk about the numbers of employees, does it matter whether they're full-time or part-time?
There's a calculation you have to go through. An employer who traditionally viewed themselves as small because they may have had only 35 employees working 30 or more hours a week. But if they have a number of other part-time employees on their payroll, there's some calculations you have to go through to determine if they are actually a small or a large group. And I could see that impacting some, particularly the not-for-profits, which had the 30 to 40 employees, because we'll find they traditionally will have a large number of salaried but part-time employees.
So there may be some combination of the two in a calculation. Now, an organization may have a difficult time coming up with that calculation. Is there a place that they can go? Or maybe a more general question is who should a small organization leadership go to seek out some of this information that they wouldn't have the expertise themselves necessarily, but need to go find some of that information? What
A
would you
number of
recommend?
sources, like they can just go online. You could put in full-time equivalents and ACA. You're going to be able to pull out a number of articles on that to tell you how to arrive at the calculation. Healthcare.gov you should be able to go to. You should be able to go to a third-party administrator. There are many sources they could go to. A broker who deals specifically in healthcare.
So you would expect that whoever it is that may be currently carrying their insurance plan for them, that broker or that advisor, that consultant should be able to provide some answers or
They
direction.
should. Absolutely.
Could you guys clarify for us we've heard the term health marketplace and exchanges and that sort of thing. Could you just describe what that is?
Sure. Do you want to take that one?
I'll let you start.
Sure. Well, actually, those two terms are now one and the same. So as in the early days of some of the details around healthcare reform, those online, not working as well as we want right now, but those online tools for shopping for your healthcare, identifying. And it's also meant to be a one-stop shop, the no wrong door idea that the administration talks about is one place to go look for both, are you eligible for subsidies? Are you eligible, in fact, for Medicaid, perhaps, instead of for subsidies for private insurance? Used to be called the exchange, changed that term to be, I think, more attractive, was to be the marketplace.
So the one and the same.
One
Yes,
and the same.
thank you.
Yeah.
Now, you made a reference to the subsidy, and I think one of the questions that I've heard from folks is that the subsidies that are available from the government for insurance, does that apply predominantly to or exclusively to the individual, or are there subsidies available to the small group or employer in terms of provision of coverage for their employees?
There's really both.
Okay.
Yeah.
Yes. The primary one, I think we hear the term subsidies can be for the individual marketplace, and it's defined based on a percentage of the federal poverty level and the number of family members. Your broker should be able to assist you in calculating that. Navigators should be able to help you with that. The Kaiser Foundation, if you just would go online and Kaiser Subsidy Calculator, and it's state-based, can help you determine the eligibility for subsidies.
And you're speaking now about the individual subsidy
Individual.
for a person, for an
Yes.
individual who's seeking to look. So
Right.
for insurance. So if you're an employer, you're not necessarily providing coverage, but you're giving some guidance to your employees or staff.
Yes.
You can pass that information along.
Yes.
What about for the employer who's providing coverage for their employees? Are
The
there
only
subsidies
thing I
available?
see is a potential credit,
Yeah.
okay? Based on the size of the employer, I think the maximum's 25 employees at this time. Going to be elevated, that can go to what's called the shop exchange, okay? And they can receive a 2-year tax credit. I believe it's 50% for the for-profits and 35% for the not-for-profits. But you have to meet certain parameters, number of employees, the average income of those employees, and the credit's only available for those that apply from the shop exchange. Whereas in 2010, when ACA first came in, there was a credit when you bought from the private insurers directly.
Thank you. You mentioned about navigators. Could you help us with who the navigators are for the marketplace, and are they predominantly helping individuals, or are they helping organizations as well?
Again, that's an individual resource available that through the Affordable Care Act provided for these different categories of folks with different levels of training, and also being paid for either federally or through state. To be available to help people navigate literally through the system. Because although it's what we've been hearing about certainly as the online websites, the online marketplace, and all of its challenges in implementation, you can also call, you can also apply for coverage, both online, by phone, and on paper. Those are the kind of folks and the resources that would help you work your way through all of the questions to determine eligibility and to determine what your choices, what the choices were that were available to you. Locally, and I think this is in your packets too, and locally wherever you are, hospitals are providing navigators and other kind of resources. Other public organizations are doing so as well. Here in Anderson, you have both St. Vincent and community hospitals that both are running enrollment events and have those navigators. And I think there's some phone numbers in your packet that you could call or put your employees in touch with if you were considering that you would not provide group insurance, that they would go individually.
Excellent. An obvious concern on the part of small organizations, if they're providing coverage, is what are the changes in the benefits, as well as the changes in the costs associated with those plans. And you referenced earlier, Dave, the issue of community rating. Is it just too difficult to make a general statement about whether someone can expect an increase or decrease in their costs if you're a small organization who's providing coverage?
If you're a small group and traditionally carried a very low risk factor, you're going to anticipate an increase, okay? Because you're going to have to subsidize those with a higher risk factor. Potentially, if you've had a significantly high risk factor, you could see some kind of decrease in your cost.
And by risk factor, do you mean the level of medical complexity of the staff or employees?
I'd say the health conditions of the employees.
So employees who might be sicker as a group
Right.
would be viewed differently than those for whom the
can
organization
no
would be generally
longer-
healthy?
In the past.
That can no longer be a component of pricing.
Right. So it's brought more even. So that makes
Right.
sense then that
Yeah.
if it's been a sicker group, so to speak, they may see some of the prices drop a
They
bit.
may see some relief.
But if it's been a healthy group, a bit of an increase.
Right.
Gotcha.
And isn't it true that many states, or I don't know many, but some states had already gone to community rating a long time ago, so they wouldn't see that as a shift. It's only in a state where that hasn't already been predominant that
That's right.
you'll feel a one-time, hit from that.
Right.
Which does bring, one of the
Yeah.
issues our audience may very well be folks from across the country. So some of these things that apply nationally, some issues apply state to state.
Yeah.
Can you give us a kind of an
Absolutely.
example of some of those things that vary from state to state as opposed to national policy or a requirement?
Well, speaking as the provider side, I guess states that had already had that kind of provision, I think we saw broader access to health insurance in a state that already had community rating, maybe before now. Also, some states certainly have had historically a much more active and more competitive individual market than perhaps Indiana has had as well, where there was more choice and more competition and all of that. So that would be a difference too, where a market, a state or an area that had a more competitive opportunity for folks to get individual insurance, possibly had less dislocation already, but also less opportunity to make that up now.
I agree with that, absolutely. Another thing I think you see in how you view states is whether they're set up their own state exchange
Sure.
or if they've decided to be part of the federal exchange. And I think where you see the state has established their own exchange, you're going to see many more options.
Yeah.
Okay, both by plans and by issuers. So I think that's one of the biggest distinctions we see at a state-by-state basis.
Great. With regard to the small group organization providing coverage for their staff, are there timelines that they need to be aware of in terms of notifications for enrollment, that sort of thing? Can you give us some direction there?
Number of issues. Number one, and I've seen some notes we passed between ourselves, you're going to have, if you're going to make a change in your benefits, that change in benefits has to be communicated to your employees on a timely basis, so they'll have the opportunity to evaluate how those compare to what may be offered through the exchange or individually. That's one. The other, the exchange notices. Whether you're an employer offering group coverage or not, you're required to issue a notice to the employees about the availability of the exchanges. Okay. Those are probably the two primary things, the exchange notices. As far as, I know a question had been, how does the small group know if they're going to be compliant? Okay, with the new law. In the majority, if they're buying products through a private insurer, those products are going to have to be compliant as of January 1, 2014. So what your offering is going to be on your renewal in 2014, going to be a compliant plan. Okay.
Is there a difference between the small business and the small nonprofit with the law?
The only thing I see is on the shop exchange, there's a differentiation of what the maximum credit is.
So the
They're
shop
entitled.
exchange is oriented to the nonprofit. So it'd be helpful for those who are a nonprofit or church to at least attend to the shop exchange option.
It should be visited. I think all your options should be visited. In the small group, we said community rating such an issue. Two other options, which probably are going to be visited by many, particularly those who are healthy, is a PEO option, professional employment organization, or we're seeing many products come out now down to 5 medical lives, which are filed as partially self-funded. And neither of those at this point in time, but as we say, everything's a series of moving parts. At this point in time, those are options to the small employer.
One of the things that has been prominent in conversations I've had, as you might imagine, is how is the law going to affect providers? How is it going to affect doctors, hospitals, healthcare systems? For employers, obviously, they might have concerns for their employees in terms of being able to select options of providers. For employees and their families. Liz, could you give us some direction there in terms of the influence?
I guess maybe we should get that off the table right away. Don't forget, hospitals are large employers, and very often in their own communities are the largest or one of the largest local employers. So, as employers, we have all the same, concerns. We're subject to the mandate because we're large employers, but we were always, providing employer-based insurance anyway. But so putting that aside, as providers of care, I guess I'd have to say that I don't think it really changes anything that wasn't well underway anyhow. So we certainly believe, as I think I opened by saying, we certainly believe that removing those barriers to accessing care, and that meant providing insurance so that people could affordably access care, hugely important. So providers will be affected by that, but in a positive way, because that's our mission, is to make sure that we're providing care and that everyone has that access. I guess you could think, as hospitals especially, who were, of course, required to provide care regardless of ability to pay, at least in emergency situations, having better access and having at least some coverage for that is going to be a benefit to us. It'll keep us from having to cross-subsidize or pass costs over to employed or folks with traditional insurance to cover the fact that others didn't. So that should be a balancing act that actually spreads costs more equitably across all consumers. One thing I guess we also have a little bit of concern about, but we think it's going to be a temporary dislocation, is just simply having a whole new wave of people have access to coverage that they didn't have before. If, in fact, they have not been seeking care or they've been delaying care, getting care in the inefficient way through the emergency room, we have a small worry about how, in fact, are we going to provide access, especially for primary care. And as primary care doctor yourself, you know that very well. So in the short run, will there be, some delays? Will there be waiting lists? Will there be, challenges getting appointments? And I guess we, worry that there will be, but hopefully that's a short-term dislocation. And hospitals certainly are trying to address that by adding staff, adding mid-levels, nurse practitioners, and others to help take that new wave of newly available patients.
Do you see changes for patients in terms of the way their health care is delivered?
Well, again, those who perhaps were making bad decisions based on lack of access to insurance, we hope that they will be getting into a primary care relationship, seeking care early, not delaying preventive care that causes their health to deteriorate, use more expensive care. But really, for the majority of people, I don't think it's going to be broadly different. Most people who had coverage already, except that it will be an equitable case where they're not cross-subsidizing to the same degree the care for people who didn't have access to insurance.
What are some good resources that you would see and make recommendation for individuals and small organizations who are providing insurance? What resources would you recommend that they look at to kind of follow the evolving changes in the law?
I know we'd had a prior discussion last Friday, and I think to look for someone in the community that employers are comfortable with doing their counseling them on how to navigate the healthcare reform. To find someone that's done this for a period of time, whether they are a third-party administrator, whether they're an insurance broker, find someone that others are comfortable with, maybe interview for those, and then maybe seek resources from the provider side,
Yeah.
which may not have been available in the past. So there are multiple options.
That's very helpful.
I think providers, certainly hospitals in every market, are trying to make those kind of knowledgeable resources available, probably, certainly much more focused at the individual level. I think in talking to some of the folks around our hospitals, they find themselves as much as anything just reassuring people who aren't affected. So the Medicare beneficiary who calls up and says, is my health care going to change? And, you know, the answer is no, but it's important and valuable to be able to reassure them.
Excellent. Is there a timeline for individuals for sign up?
Absolutely.
And what do they need to do and by when?
Yeah.
Well, from the individual side, there was an initial open enrollment, which began October 1, but it's running into a few bumps, as everybody's aware of.
Yeah.
For the first year, it's supposed to be extended open enrollment to March 31st, I believe. Might that be extended further because of the difficulties on the front side? Purely speculative, but I think probably will be the case. I mean, this is just a very difficult task. I don't think anybody can be held at fault for this. It's a real challenging transition, and you've got numbers coming in, numbers of potential members that you've never seen before.
Yeah, the level of complexity of the system is significant, and the amount of impact in our society, just financially, is significant. And so, trying to put all of that together for employers and individuals and families, for healthcare providers, certainly has its challenges.